We'll go ahead and get started. Hi, everyone. My name is Lola Nedich, and I am the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box if you'd like. And now, before we get started, I just want to review a few housekeeping items. Next slide, please. Okay, so participant microphones will be muted at entry. You'll be able to unmute them during the discussion portion. If you have questions during the event, please use the chat. If you have any technical difficulties, you can also message me. This session is being recorded and it will be emailed out to all participants once it becomes available on the website. If you have questions after this session, please email newengland@mhttcnetwork.org. With regards to certificates, we send a certificate of completion at the end of the month that you can submit to your particular board for continuing education credits. Please contact ifisher@c4innovates.com for more information on CEs after the event. Next slide, please. These are some MHTTC acknowledgements. Next slide. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I will hand it over to Raquel for introductions.
Thanks so much, Lola, and good afternoon or good morning, everyone, and thanks for joining us today. So my name is Raquel Meshalem-Gately. I am a psychologist from the Beth Israel Deaconess Medical Center in Boston and co-director of the Beth Israel Deaconess site for the New England Mental Health Technology Transfer Center, or the MHTTC. So I'd like to welcome you to today's webinar, which is part of an important series of initiatives we launched a couple of years ago through the New England MHTTC to help support the well-being of healthcare workers experiencing an increase in stress-related psychological difficulties resulting from the COVID pandemic. So now, though the pandemic is largely dissipating, some impacts linger, particularly regarding mental health, and we're learning more about these effects, both throughout the past 3+ years and continuing now. So to that end, I am delighted to welcome Drs. Keshavan, Shute, and Keshava to teach us about the psychiatric, neurological, and social aspects of the pandemic. And I'm going to begin by introducing Dr. Keshavan, who will then introduce the other speakers. And I'll just caution by saying that this is going to be a very brief introduction, because if I listed all of his accomplishments, we'd be here for a very, very long time. So Dr. Keshavan is the Stanley Cobb Professor of Psychiatry at the Beth Israel Deaconess Medical Center and Harvard Medical School. He is also the academic head of the department and director of our Beth Israel Deaconess site for the New England MHTTC. Dr. Keshavan is closely involved in research in the neurobiology of psychosis, especially as it pertains to first episode psychotic disorders. And he is a board certified psychiatrist. So without further ado, Dr. Keshavan, take it away.
Thank you, Raquel, and good morning, good afternoon, or good evening, everyone, wherever you're listening from. It's my pleasure to introduce today's speakers and also the topic. So we thought of putting this together. We, as Raquel mentioned, we are kind of at the end of the pandemic. In the US, the pandemic was officially declared ended by sometime in the spring of this year, in May. And even though it continues to be there throughout the world, in one way or the other, either there's an epidemic or in an endemic way. And so we thought that this would be an opportunity for the New England providers and other in the audience, a stock taking of where we are. What have we learned from the COVID-19 pandemic? This is a topic of relevance and importance to pretty much everyone, because the whole world has gone through the pandemic. And all of us have been affected by, in one way or the other, by the disease directly, ourselves, our family members, our friends, our society in general. And 3 years down the road, where we are and what have we learned? And since this is a mental health related webinar, I thought that it would be best to put together a group of 3 perspectives. One from a psychiatry side, which I will do that, and from the neurological side, we have Dr. Keshava, who shares my name, but also I have to say shares some of my genes because he's my cousin. He's a neurologist in Mysore. He's also a professor of neurology at the JC Medical College in Mysore, which is a beautiful town in South India. And he has lived through the pandemic in India, which was one of the most affected, in some ways, very successfully handled the pandemic over the years. And he's going to tell us more about it because he has seen it both as a practitioner and as someone who has seen how the country has evolved with the epidemic. So Keshava is a neurologist who trained in medicine and neurology and is currently practicing in the town of Mysore. And Professor Russell Shute, who is a sociologist who I have the privilege of working with, we call him Russ. Russ is a scientist who has studied the social determinants of health in many ways, and is part of our large intervention study for serious mental illness using cognitive remediation. And his work is broad ranging. And in the last few years, he has actually led a major study in the Boston area of the impact of COVID on mental health. He's going to tell us about how COVID has affected mental health broadly and its implications for how we can potentially get ready for anything like this in the future. So with that as the backdrop, let me start with my first slide here. Let me see if I can move here. Okay. So as I said, the pandemic has largely dissipated around the world as of July 2023, and the official end to the pandemic was declared in May, as I said. And those figures are kind of self-explanatory with the total number of new cases as well as the daily deaths. Unfortunately, the world has witnessed several million people end of their lives and a huge amount of adverse impact on families and societies. So now this is a slide from early on post-pandemic, which was quite circulating quite often on the internet, and is a very informative slide as to how COVID has impacted all of us. And there are at least 4 different kinds of waves of impact of COVID. The first, of course, is the immediate mortality and morbidity caused by this illness, which we have all seen. And then the second wave is, during the pandemic, when most healthcare resources were focused on COVID, a lot of non-COVID conditions, whether it's heart disease or cancer or serious mental illness, they got pushed to the side. So that is the impact of such resource restriction on urgent non-COVID conditions, and how we dealt with that was like the second wave. And the third wave is the impact of interrupted care and also interrupted healthcare systems on chronic conditions. And then the fourth wave is really the downstream effects of the pandemic, not only on the physiology of individuals, but also on society and people's lives in terms of economic injury and burnout and job change, job loss, and so forth, and the psychological consequences of that, which is what we are nowadays dealing with. And in order to put this in perspective, we need to think about any disease which leads to a pandemic like what we have seen. how do we understand the causal factors that underlie these disorders? And in epidemiology, we use a term called epidemiological triad. There is always the agent, which is like the virus, the host, which is our physiology, our immune systems, and so on, and then the environment. So in order to understand the consequences of the pandemic, we need to know all of these, where we come from in terms of the effects of the virus, the effects of the medications, the iatrogenic effects, the medical comorbidity, the genetic risk, the kind of healthcare we receive, and also factors such as economic deprivation, age, race, socioeconomic status, psychiatric comorbidity, and so forth. And then how our healthcare system overall responds. So the medical side of it, how the brain is affected and responds, is something that I'm going to leave to Dr. Keshav, who will come after me to speak on. And the social side of it and how society has been affected, I will have Russ Shute to speak more about it. And I'll speak more about the psychiatric phenomena that we have observed over the course of time. And at the beginning of the pandemic, we thought that this would be a snowballing phenomenon, which in many ways it has turned out to be. COVID may be the beginning of this domino effect, but then there are a number of things that we saw, which included healthcare disparities, potential discrimination, economic downturns, and so forth, and how it affected politics and law and order and so forth. All of these are consequences that have an impact on health and mental health. Now, let's take in turn what has all happened in 2023, looking back. If you look at the world economic situation, in 2020, with the pandemic, there was clearly an economic downturn, as you see here in this graph. Across the world, as well as developed economies and developing economies. But then it looks like, looking back now, there has been a bounce back on some of the economic indicators. It's a rocky recovery, but some recovery nonetheless. In fact, every day we hear on the news about economists of one color or the other coming and forecasting that the recession is not going to happen. Of course, there's always ongoing debates about that and so on. So we're in the midst of thinking that economy is not that bad, and maybe, at least in many countries, on the road to recovery, even though in some others it may not be in such a situation. But what about mental health? So this is a paper from 2 years into the pandemic, or a year and a half into the pandemic, and one of the largest studies published in Lancet of over 200,000 people, which showed that both dementia and psychiatric disorders like mood and anxiety disorders, as you see in that red line, increased since the onset of the pandemic, quite substantively, and in fact, more so with some of the neuropsychiatric disorders like dementia. On balance, it was found that kids were affected even more than the overall general population. And this is a survey last year from the Pew Research Center, which said that on balance, the impact of COVID has had a negative impact on kids' education and well-being. 61% of the people in this large survey said that it is somewhat negative, and in terms of education, and about 48% said it was somewhat negative or very negative in terms of emotional well-being. And in the same survey, it was also found that young adults, especially likely to have experienced high psychological distress. And if you really look at these surveys in the US, the people that were more affected by negative mental health impact are, as you see here, younger people, women more likely than men, younger and Black, Hispanic, or Asian populations, more so than white populations. Younger people, those aged 18 to 29, and those in the lower income strata, and also those who are living alone. So this is kind of borne out by several other studies, or smaller studies, showing that the people who are living alone, especially elderly population, as well as young population, and the more disadvantaged, poorer sections of society are more likely to be affected. What has happened to other indices, such as gun violence? In the United States, gun violence seems to have increased since the onset of the pandemic, with a 23% increase since 2019, and homicides increased by 40%, 45%, gun homicides and gun suicides by about 10% in the same period. The reasons for these might have been social disruption, economic insecurity, fear, uncertainty, and increased gun ownership. What about suicide? Per CDC data, the Center for Disease Control, suicide initially declined in 2020. This is not surprising, because in most pandemics historically, during the pandemic, suicide rates tend to go down, but they tend to go up afterwards, which is exactly what we saw. And the effect of the pandemic on mental health and generally on severe consequences, including death, appears to be disproportionately larger in the African American and indigenous and Pacific Islander communities in the US, as you see here, compared to the Asian and white. So there is a disproportionate impact of the pandemic on minority populations. So the racial disparities also is paralleled by disparities across the pre-existing conditions. There is considerable data that those with comorbid medical illnesses tend to have a higher frequency of death and disability and hospitalizations. And it was also found in a large study in New York that the death due to COVID-19 was much higher, almost 3 times higher in the people with serious mental illness like schizophrenia compared to those without. So this is an important thing to keep in mind, the disparity across ethnic and demographic divides, as well as disparities across psychiatric illnesses. Those are, it may be that those with psychiatric illnesses do not receive care in an optimum way, or that they may not have received vaccinations and so forth. We don't know the answers to those. And in response to the pandemic, several changes were made in the US in terms of the delivery of mental health and substance abuse disorder services. For example, restrictions on clozapine monitoring was removed soon after the onset of the pandemic. The shift to telehealth happened right away, which I'll show you in another slide later. Congress lifted provisions that limited telemedicine services to all beneficiaries for fee-for-service. And also the restrictions on opiate treatments like buprenorphine, Suboxone, they were removed early on this year, increasing the number of people receiving buprenorphine prescriptions. So just to point out here that one of the negative consequences of the pandemic was a worsening of the opiate epidemic, which was already a pretty bad thing in the US. Also, increased funding to train and expand mental health providers in schools is something that is good that happened. And several suicide, drug, and violence prevention programs were instituted. And also, good news is the launching of this hotline, the 988, which was launched last year. It's an easy to remember a number for suicide and behavioral health crisis. We always have had the 999 number for any emergencies, but 988 is a new thing that you can get immediate and quick services into mental health based on 988 codes. Locally, in our own setting, we looked at the frequency with which, following the pandemic, a shift to telehealthcare happened. And as you see here, over 80% of early psychosis treatment programs switched fairly within months of the pandemic to remote care. And of the services that began getting offered virtually included individual therapy, family therapy groups, supported education and employment, and diagnostic services, and so forth. So, which is a good news. But interestingly, we also looked very recently in our own MapNet project, what has happened to service use across patients. Interestingly, as you see here on the left part of the slide, compared to pre-pandemic, and then we compared pre-pandemic, we called early pandemic as the period from this onset of the pandemic in March 2020 to the time when vaccines were widely available, which was May 21. We call that the early pandemic. And after the May 2021, we call that the late pandemic. Service utilization for mental health services actually went down, whether it's medications or therapy services, psychotherapy, family services. People began using mental health services less than they should be using. We don't know whether this is because less were available or simply for some reason or the other, people began not using them, whether it's due to lockdowns or social distancing and so forth. So this is an important observation. We still need to understand and study this. But by contrast, what we were surprised is that those that did receive services, their satisfaction did not go down. So this was an interesting contrast. They are getting, some of them are getting services and they are happy with the services, but a lot of them are not getting services, which is something that we have to think as a healthcare service group. Now, let me switch on to other things that we have learned over the last 3 years. Initially, the focus was all on what we call the immediate post-COVID consequences. Dr. Keshav will touch upon some of those from a medical and neurological side. But over the course of time, we have learned that nearly 20%, about 1 in 5 people who have had COVID have what is called long COVID, which is a combination of multiple symptoms, many of which are psychiatric problems, anxiety, depression, brain fog, memory problems, fatigue. And one thing that has become quite interesting over the course of time is that if you look at the symptom profile of what we call chronic fatigue syndrome, which is a condition for which we don't know the causes, it may be an immune problem, or it may be something to do with some viral exposures and so on. You can almost completely overlap the frequency of COVID, long COVID symptoms onto the syndrome called chronic fatigue syndrome or neuromyalgia syndrome. The other thing we have learned is that there are some risk factors which increase the likelihood of someone developing long COVID. Long COVID seems to be more common in women, more common in unvaccinated individuals, which suggests that vaccines may have some protective value against the so-called long COVID. And Keshav will explain more about long COVID as to what causes it and so forth. People who have pre-existing problems like asthma or obesity are more likely to develop long COVID. Those who already have depression or anxiety are more likely to develop long COVID. And also those who had more symptoms during acute COVID are more likely to develop long COVID. Unfortunately, thus far, over the last 3 years, no standardized tests or biomarkers have been developed for long COVID, and no specific treatments have been developed. And a number of treatments are being researched, including antiviral compounds, anti-inflammatory compounds, even cannabinoids, antidepressants like fluvoxamine, and mood stabilizers like lithium, and also exercise and yoga. Dr. Keshav is going to bring to you a couple of case illustrations of long COVID. And several guidelines are being developed on long COVID for clinicians, and a multidisciplinary care that includes several disciplines, including neurologists and physiotherapists, critical care specialists, anesthesiologists, pain medicine specialists, psychologists, and psychiatrists. So multidisciplinary care is important, and primary physicians should have a good handle on how to understand this condition. Patient self-reports are very valuable because there are very few objective markers that one can see on physical exam or in laboratory tests, but it doesn't mean that the patients are not suffering. So self-reports are very, very valuable. And also to monitor symptoms in an ongoing way, digital technologies using smartphone apps, which many of them are available, including our own Mind Lamp. And also societal changes. Long COVID, for example, has now been recognized as a condition that could be defined under the American Disabilities Act. And we also, as a society, have learned a number of things from the pandemic. And first of all, that mental health is a continuum. There is no health without mental health. And there is no mental health without physical health. All of this might be helping to reduce stigma on mental illness. And also, we are learning that we need to learn coping skills, spending more time with family and friends, engaging in hobbies. Not so much social media, but Dr. Schut is going to be telling us more about that from his own data. And also, we are learning about the importance of social determinants of health in understanding why some people do develop difficulties and some do not. Age, gender, work status, pre-existing conditions, health insurance, and so forth. We are learning more and more of that. And of course, we are learning that we all need each other, and we are all interconnected and interdependent. It's good to be caring for each other when ourselves or others are suffering or struggling. So in conclusion, from my part of this webinar, I would say we are learning that mental health impact of disorders continue probably just like we have seen in previous pandemics, including the Spanish flu of 2017. Mental health impact typically last many years, even beyond the end of a pandemic. And we are seeing that. And secondly, we are seeing that there are continuing problems which pre-existed the pandemic, but are continuing. That is the lack of parity between medical illness and mental health conditions, and also negative mental health impact among people of color and women and children. We are learning more and more about those. We are also learning that gun violence has been increasing, and possibly suicidal rates are going up. And the world has switched more and more, maybe for good, towards remote and telehealth. And of course, we need better reimbursement for new services of telehealth and digital services. And also, we are learning more about long COVID, which is a common and a disabling problem, but we still don't know how to treat it. And finally, as we emerge from the pandemic, we are realizing that there is an increased need for mental health and substance use services so that we be ready in the future. If a similar pandemic emerges again, we have to reshift our resources in an efficient and nimble manner to meet the needs as we go forward. So clearly more research is needed. So I'll stop my part of this webinar here now, and I will switch. I'll ask Dr. Keshav to share his slides. So let me stop my sharing my slides here. Okay, so Keshav, you're all, yeah, take it from here. You're muted.
Yeah, can you hear me?
Yes.
Yeah. Can I start now?
Yes, please.
Yeah. Hello, everybody. Good morning and good evening. I would like to thank Dr. Professor Keshwan and MHTC who made it possible for me to use this platform and discuss our experience in the Indian medical health setup of what exactly we faced about during the COVID-19 pandemic. Since it's a heterogeneous audience, I'll not go into the details and depths of pathophysiology or clinical management, but I would like to stress more on the long COVID, which actually we are all seeing right now, especially neurologists and psychiatrists, and probably many other physicians too. I'd like to comment a few complications what we encountered after the COVID vaccination, what we had on a very huge, massive scale in India, and the pandemic, what challenges it threw to us, and how we try to overcome them, and probably we did succeed in that. So my talk will be brief, and of course, stressing a little more on long COVID, as Dr. Keshwan had mentioned. Now, we all know that the COVID-19 virus is just a new kid on the block. It's the same old coronavirus virus, which probably have mutated and became more virulent, so virulent that it was able to spread widely and fast all across the world, causing the pandemic. Well, it's a single-stranded enveloped RNA virus. Because of the crown-like morphology, it was called as corona. This is one of the viruses which are neurotropic. That means it replicates in neurons. Hence, we saw that many cases of acute COVID had a lot of neurological complications and a really very widespread involvement of the nervous system. It enters the central nervous system basically through the, that is angiotensin enzyme 2 receptors in the olfactory bulb. So just to say, explain, infected patient, when he sneezes or coughs or sometimes even may laughs loudly, the droplets containing the viruses may be inhaled by a susceptible host. It lodges into the nose, the endothelium, and through the olfactory bulb reaches the central nervous system. And here it has a very high propensity to involve the brainstem, resulting in limbic encephalitis. This sort of encephalitis unfortunately leads to respiratory failure. And that was one of the reasons for a very high mortality in what we see in COVID-19 patients. Well, for the virus to involve the nervous system and cause neurological complications, it had to enter or through the very strong defense barrier of the nervous system, what we call as the blood-brain barrier. So initially, it was thought that there could be a direct viral invasion through the blood-brain barrier, which is really very uncommon. It could be transcellular through the host cells or through tight junctions, paracellular migration. But very commonly, we see that this virus is smart enough that it just infects either the immune cells like the macrophages or phagocytes, and these cells, immune cells, act as a Trojan horse, which help the virus cross over the blood-brain barrier and enter the central nervous system. Now, why did this virus cause so much of havoc, so much of damage, so much of multi-organ damage, what we all witnessed during the acute phase? This is because it has been mentioned that there are so many reasons. One of the most common thing is bioenergy failure. We all know that the mitochondria is the energy house, the powerhouse of the cell. So the virus which infests the mitochondria causes a severe bioenergy failure, of which the cells and the tissues die off. Because of the virus, the host mounts a systemic immune response. We have a lot of inflammation, the infiltrating T cells, macrophages. I'm sorry. And when these immune cells, they try to destroy the viruses, invariably the tissues also end up in collateral damage, and hence we have so extensive damage involving the lungs, the kidneys, and the different organs of the body. And one of the most important reason or the pathology, what was very common involving all the organs, was this endothelial injury. So the virus damages the endothelium of the blood vessels. This results in either venous thrombosis, ischemia, or sometimes even microhemorrhages. There is a hypercoagulable state which results in blockage of the coronary arteries, resulting in coronary artery disease. It can cause the cerebral arteries blockage, causing various types of strokes, both arterial and venous, similarly involving all the arterial system of the body. Over a period of time, these viruses also initiate or trigger of the autoimmune response. And because of that, long-term, you can have destruction of the myelin sheath of the peripheral nerves and all the muscles. So ultimately what it does is, through all these different mechanisms, the virus ensures that these different organs of the body are damaged, and hence the very high mortality and morbidity what we saw during the acute COVID infection. Now, the acute syndromes were many. Initially, some of them were very mild, like just anosmia, or that is loss of smell, or acusia, that is loss of taste sensation. In fact, during the pandemic, any patient who came to us with history of fever and loss of smell, the first diagnosis what was, is it COVID? That was the most common symptom. Then, of course, like we had very severe neurological complications like stroke. This was because of the hypercoagulability and the endothelial damage resulting in thrombus formation, the platelet aggregation and thrombus formation, which I had explained earlier. Many of these patients had acute encephalitis, the COVID-19 encephalitis. This was because of the disruption in the blood-brain barrier, resulting in severe neuronal damage. Over a period of time, many of these patients invariably develop peripheral neuropathy, as I told you, because the antigen of the virus very closely mimics the antigen of the myelin sheath around the peripheral nerves. So the antibodies produced by the body to destroy the viruses also start destroying the myelin sheath. Hence, patients present with severe peripheral neuropathy, like what we call as Guillain-Barré syndrome, or acute inflammatory demyelinating polyneuropathy, and so many other conditions. Many patients did complain of severe muscle pain, weakness, due to either myositis or myopathy. And this was basically because of the bioenergetic dysfunction. Now, as the acute symptoms passed on, and once we were almost heaving a sigh of relief, then there was a surge of patients who started coming back with various neurological complaints, but which were not very specific and not localized. Invariably, it was very difficult to put them or to localize them to one particular part of the body or an organ. So there were a lot of terminologies which were being used, like PASC, that is post-acute sequelae of COVID virus, or ongoing symptomatic, or post-COVID-19 syndrome. Since this was causing a lot of confusion, ultimately it was decided unanimously that the long COVID was probably a more appropriate terminology. Now, why do we use the term long COVID? Because this is a symptom, or this is a syndrome complex, which we are witnessing, which we are seeing after the pandemic is really over. And it is almost like all of us physicians across the board do see it. Only thing is probably maybe some of us are recognizing it, some of don't. That's the reason why I was just labeling it as it's the elephant in the room. Yes, we need to recognize it. We need to really treat it and make sure that this elephant does not go berserk. The long COVID consists of two basic conditions. Either it could be the ongoing symptomatic COVID-19 and the post-COVID-19 syndrome. So if the symptoms and signs last for 4 to 12 weeks, we call it an ongoing. Whereas if the symptoms continue for more than 12 weeks, then we call that as a post-COVID-19 syndrome. But here, the caveat is that it should not be explained by an alternative diagnosis. So most of the times, we need to do a couple of investigations or a detailed evaluation to ensure that this long COVID, what we are diagnosed, is not because of an underlying complication involving either the central nervous system, the cardia, the lungs, or any other organs. Now, what are the mechanisms of long COVID and what's the pathogenesis? This is a little interesting because the COVID virus, though it causes so acute symptoms, it does cause a lot of havoc and mischief in the various systems of the body. First and foremost is the immune system. It causes a sort of immune dysregulation. So what happens is, following a COVID infection, the immune system, there is dysregulation in the immune system in response to any further infection or a microorganism. So either it may be a suppressed reaction, or it may become hyperactive, producing far more immune response than what is naturally expected. Moreover, it also reactivates on the underlying latent virus or latent pathogens, including the herpes virus, the Epstein virus, and the human herpes virus 6. So what happens is, there may be a continuous viremia going on in the human body, which is responsible for the various symptoms of tiredness, fatigue, low degree fever, myalgia. So all these symptoms may be a symptom of an ongoing viremia, which may not be COVID-19 infection itself. The coronavirus also is found to have caused a microbiota dysbiosis. It just means that the normal microbial flora in the intestine gets disrupted. So the so-called healthy microorganisms either are suppressed, or the unhealthy or the pathogenic microorganisms have an upper hand. And as we all know, the gut has a very direct influence on the immune and the endocrinal system. So both the systems get affected when you have microbiota dysbiosis following the COVID infection. The third important reason is, as I mentioned earlier, it primes the immune system and the autoimmune process sets in. So many times antibodies are produced against the body's own, either the peripheral nerves, the muscles, the different organs of the body, which start destroying the immune system, which start destroying the organs and cause a lot of conditions which may be attributable to the autoimmunity. And the endothelial damage, the process of thrombus formation does continue long after even the acute infection is over. So that's the reason the microvascular blood clotting with endothelial dysfunction continues even in long COVID. And one more important cause of the pathogenesis of long COVID could be because of a dysfunctional neurological signaling. As we all know, the brainstem, the vagus nerve, basically the sympathetic and the parasympathetic systems in the body are in a perfect equilibrium. Now, by some mechanism, this coronavirus disrupts this signaling, so that again, there's a lot of autonomic dysfunction. Hence, we see a lot of these cardiac symptoms, like patients can have POTS, that is the postural orthostatic tachycardia syndrome, hypotension, or sometimes they can have severe hypothermia followed by fever or hypothermia. So all these dysfunctional neurological signaling is also probably responsible for one of the symptoms of long COVID. As I had mentioned earlier, these symptoms of long COVID can affect every organ or different organs of the body. So you can have the brain which is affected, like they can have cognitive dysfunction, depression, anxiety, insomnia, or the patient complains of brain fog. It's a very common terminology what the patient uses. Of course, they use in their own vernacular language, but what they mean or what they try to convey is that they're not able to concentrate. The brain is fogged, sort of the clarity of thinking, the logical thinking, the time to take decisions or taking quick, fast decision on the foot, they somehow are not able to do that. They call it as a brain fog, which is actually very, very commonly seen in patients with long COVID. They can have the anosmia, the loss of smell, the loss of taste sensation may persist. And believe me, it's one of the most distressing symptoms, because many times patient comes that he says, I feel like I'm eating rubber, which is a really very distressing symptom. And unfortunately, we really have no the immediate therapeutic cure to treat his symptoms. They can have a long persisting headache. Sometimes they can have dizziness, tinnitus, which is also very disturbing and annoying to the patients. Well, they can have symptoms involving the cardiac system. They can have chest pain, shortness of breath, involving the GI system, like the irritable bowels, lot of muscle aches, pains. All these symptoms are very commonly seen in long COVID. As Dr. Keshwan had mentioned, since it is involving different systems, a multidisciplinary approach is really advisable and is the need of the hour. I would just like to illustrate one of the cases which we encountered a couple of months back. Mr. K, he was a 46-year-old gentleman, a non-diabetic, non-hypertensive. He was a senior executive in highly placed in a company, very active professionally and in his personal life. He had COVID pneumonia with respiratory failure. He was in the hospital for 2 weeks and then was discharged. 8 weeks later, he came to us with decreased attention, poor concentration. And when he went back to the office, he says that he found it difficult to attend meetings because he had to be prompted very frequently by his assistants to take decision or to answer. It was taking a long time for him to take decisions. He was not able to multitask as he used to do before. He had to be prompted very frequently, and he was just not able to put in the working hours which he used to do before. So when this went on for quite some time, he had to resign from his job and was really unemployed for some time. Well, obviously this led to depression and anxiety. He presented to us. There was no focal neurological deficit on evaluation on clinical examination. Of course, we did a MRI scan brain, MRA, also to see whether there was any vascular event, whether there's anything else which could have affected the brain, but there was nothing specific seen on the MRI scan. His neuropsychological evaluation showed that he had mild depression and anxiety. Since all the other investigations were normal, a diagnosis of long COVID was made. So patient basically was counseled. We started him on cognitive rehabilitation. We encouraged him to engage himself in more recreational activities. We did start him on some neuroprotective agents, neuroprotective drugs. The family were counseled to basically to give him a lot of emotional support and help him cope up. He did change to a less demanding job. Over a period of time, he said that he was getting back to normal, though he did not come back to his original pace of functioning. And he did say that, he was a bit slow, but at least he was functionally independent, was able to come back to work. So this just shows to illustrate sometimes the brain fog or the cognitive dysfunctions, what we see in long COVID may leave behind some amount of neurological deficit with not a complete recovery. This chart or this cartoon just shows, as I was telling you, the different symptoms of long COVID. Right, as I told you, like the exercise intolerance causing muscle weakness, exertional dyspnea, or fatigue. You can have different pain syndromes, and these pain syndromes can also be very distressing to the patient. They can have neuropathic pain, they can have severe paresthesias, and this can lead to a lot of sleep disturbances, insomnias. They can have headache, tinnitus, dysautonomia because of the neuronal dysregulation. You can have palpitation or the POTS syndrome, and the cognitive mood and sleep disorders, which I had mentioned earlier. So the long COVID basically involves a lot of these symptoms, lot of involving different organs of the body. Another case, we had a 32-year-old lady. She was a dental surgeon by profession. She was married with 2 kids. She developed a COVID infection, which was actually mild in the first and the second wave of infection, recovered with ward admission and drugs. And at the time of discharge, there was no focal deficit. But 6 weeks later, she presented with persistent tiredness, easy fatigability, unable to perform a regular domestic course. She had even difficulty in fulfilling her family responsibilities. She was very active physically, taking part in sports and games. Unfortunately, now she mentioned that taking a walk around the block, she was not able to do so. This tiredness and fatigability was really very, very annoying, and she was finding it difficult just to function normally. Investigations, including the metabolic, the hormonal workup, all were within normal limits. At the periphery health center, she was diagnosed as fibromyalgia or a post-viral myalgia, but we thought probably it fits into the condition of long COVID syndrome. She was treated with multivitamins, supplements, counseling. She was asked to get back to her regular physical activity at a slower pace and then slowly, incrementally, step by step. Along with that, we did advise her other terms of therapy like the yoga, which does help to handle the stress and the pressure of the work as well as the post-COVID syndrome. She was asked to do some meditation, breathing exercises, what we call as pranayama. Over a period of time, she did improve, and within say 8 to 12 weeks, she reported that she was back to normal. So this was a happy ending for a long COVID syndrome, which is really welcome. It just shows it goes to show that if we have a multidisciplinary approach, definitely long COVID syndromes can be really treated. I would just like to stress, make a few points about the complications what we saw after COVID-19 vaccination. So in India, we had 2 types of vaccine. Just want to highlight that we had one what was called as Covishield, which was produced by the Serum Institute of India in association with AstraZeneca. This was a recombinant replication deficient chimpanzee adenovirus vector encoding the spike glycoprotein. And of course, like after administration, this induced the antibody protection. The other vaccine was we had what is called as a Covaxin, which was a whole virion inactivated virocell derived platform technology. So of these 2 vaccines, as we administered these vaccines in large numbers, over a period of time, we did see some neurological complications. Of course, the incidence of these complications are very, very low. It is supposed to be something like 0.05% or sometimes even 0.001%. But since the number of vaccines what was administered in India was huge, like almost like for a population of 1.4 billion, almost about 80% of our population did have vaccination. So that was the volume of vaccinations. And we did encounter some neurological complications. Many of them were very mild. like some cranial palsies or abducens nerve palsies, some cases of Guillain-Barré syndrome, the peripheral neuropathy are seen, and a few cases of probably cerebral venous thrombosis were seen. But the catch here was this happened during the ongoing viral epidemic pandemic itself. So it was not sure whether it was a vaccine which had caused this or whether it was an underlying viral pandemic itself which could have caused this neurological complication. But the good part of it is most of these complications improved very well with symptomatic treatment, and there was no long-term neurological deficit. I would like to conclude by telling about the experience of what we physicians in India faced during the pandemic. Well, this was the experience in general of all physicians who we treated COVID-19 pandemic. The first wave hit our country between March and September 2020. Well, initially it was prepared, so the authorities had completely clamped down. So we had lockdowns, all the business establishments, factories, industries were all closed. So naturally, when the infection, the pandemic did hit us, the cases were more or less manageable. There was minimal disruption of medical supply chains because most of it was all very few cases, and the ICU beds were able to manage it. After a few months, the lockdown was lifted and the economy was back to normal. And the second wave hit us really like a tsunami because we had hundreds and thousands of patients entering the hospitals. We had to admit a lot of those patients who had acute complications in the ICU. Unfortunately, there was a very severe shortage of beds. The medical infrastructure was really not prepared to take up this severity or this extent of cases that had were entering the hospitals. So there was a shortage of beds, essential medicines, and yes, most importantly, oxygen supply was also in very severe demand. So it was a really very torrid experience for the patients because the families had to keep literally running from hospital to hospital trying to get beds. We in the medical fraternity, we are also frustrated because everything was difficult to manage with so much of shortage, and of course authorities were also at the wit's end. Gradually, over a period of weeks, it did stabilize, and then we had the two indigenously manufactured vaccines, the Covaxin and the Covishield, which was available for the general public. So usually we call them as a white knight because they really saved us the situation for us. And in India, we have the universal immunization program, where every child under the age of 5 years, be it in the remotest villages, either in the cities, towns, rural areas, or even the hilly villages, they are all immunized by a very good network of healthcare workers. So you have the ASHA workers, what we call here, the workers who go to each house and ensure that the child is immunized. So this network of the vaccination program was leveraged to vaccinate, to ensure that the COVID vaccine reached each and every individual of our country. Along with this, we had what is called as a COVID web portal. This was very good because every individual, every citizen, we have what is called as an Aadhaar card, which basically gives us the identity of a citizen. Using this, we had to enter the portal, and so that it was very easily to monitor and ensure that all the citizens, all the individuals were vaccinated. And of course, the authorities used a carrot and stick policy. So it was made mandatory to wear masks, especially in public spaces, and literally they were fined and penalized anybody found in public not wearing a mask, which was a stick approach. Of course, the carrot approach was people only who were vaccinated were allowed to enter into shops and business establishments, and even the employers ensured that the employees all got vaccinated. So this really helped in making sure that the coverage of the vaccine was wide and extensive, and it happened pretty quickly. We were able to ensure that in a very short period of time. So by the time the third wave hit us, that was between January and March 2022, the infrastructure had improved. Yes, we had learned the lessons the hard way, but we did improve. Availability of drugs and oxygen was definitely better, and there was no shortage as such. And the best part of it is that a hybrid immunity had developed amongst majority of the population. What it means is that more than 60 to 70% of the population either had been infected by the natural infection or had taken vaccine. So ultimately, the virulent virus had no susceptible host to spread to. Naturally, the third wave had a very lesser impact, reduced mortality, and of course, a very low morbidity. The newer variants, the mutants of the COVID virus kept hitting us, kept coming to the country as any other countries. So later on, we had the Delta variant, the Omicron BA, the Delta Cron, the BA H3N2 variants. So many variants, but fortunately, all of them were less virulent. They had reduced complications and very low ICU admissions. By this time, of course, the people were educated, they were aware of that, and definitely the human spirit prevails so that the pandemic was brought under control. My closing thoughts would be one, that this is still an ongoing infection. Well, the pandemic is over, but definitely we are still seeing a lot of mutants, lot of variants of the COVID virus. It's a constantly changing symptoms and clinical signs. So symptoms, what we saw at the beginning of the pandemic, like anosmia or loss of strain, now it has totally changed. So people is present with nausea, diarrhea, or sometimes they have this red eyes, the pink eye syndromes and all we have seen. So from the pandemic, it then changed to the epidemic. And now we feel that it has become an endemic, probably localized to a few pockets in the area. The last word has still not yet been written about the pandemic. It has definitely caused a huge burden on the health infrastructure. It has caused a lot of economic hardships, which people are still recovering. Not many people, unfortunately, have totally recovered. It does definitely has a lot of left behind a lot of hardships. There has been disruption of the delicate family and social fabric because of this. It has been a continuous learning process for the entire medical fraternity. Yes, like at the beginning of the pandemic, we are all at loss to know what it is, because this was a totally different or totally new infection. So we had to learn learn about the pandemic as the disease progressed. And probably over a period of time, we did know what works and what medicine doesn't work, and we were able to handle it better. So that is what I would conclude and say that, yes, the pandemic has been was very challenging for the medical fraternity in the country. Initially, as we all probably resolved that we shall overcome, and probably by the end of it, I think we can probably say that we did overcome. Thank you for your patient hearing.
Thank you very much, Keshav, for that very, very helpful overview. So since we have, this is a 1.5 hour webinar, we do have some time for discussion at the end. So I request Russ Shute to make his presentation. I'm going to share his slide. So I'm going to stop your slides, or you can stop your slides, Keshav, and then I'll share mine. Oh, great. Okay. So let me see. Okay, so this would be the first slide of Dr. Shute. So let me put it on slideshow mode. Okay, so there we started from the beginning.
Kesh, we can see your speaker notes, so you'll have to go back to the display settings.
Okay, so let me see how. The current slide. Do you still see the, yes, oh, display settings. So this is better, right?
Right.
Yes.
So I'll skip to Russell's slides. So we have a very quick overview now as I switch the slides again. Okay, there we go. Russ.
Thank you, Dr. Keshavan, and it's a pleasure to have the opportunity to speak with all of you today. I'd like to begin by emphasizing that what I will be reporting on are the results of a survey of the general population across Boston's neighborhoods that was funded by a National Science Foundation Rapid Response Grant. It is not a survey of persons who were infected with COVID, nor was it a survey focused on persons with serious mental illness. Moving to the next slide. Instead, what we looked at was the general effects of the experience of the pandemic in the population, distinguishing economic and mental health effects, and looking at, in particular in this presentation, on how the subjective experience of declines in mental health varied across different population groups. So if we can proceed, next slide. So this is a brief summary of the survey selected to represent all 25 of Boston neighborhoods during the summer of 2020. Again, early in the pandemic, it was a random address-based sample with an initial distribution through the mails, what has now become a very respectable 27% response rate. And I'll also bring in some data from a prior panel to show something about the changes. Next slide. We measured, as I said, subjective reports of changes in personal income due to the pandemic and changes in mental health since the pandemic again, and also focused on aspects of changes in individual social connections. Moving forward, I'm going to first present some selected general changes that we identified in the survey, and then provide a more multivariate picture of what was influential in terms of mental health. This slide shows the fraction of the population that was reported that their personal income, family income, was affected by the pandemic. And you can see that's over 1/3 of the population of Boston. Moving on, the next slide reports on individuals' assessments of how their physical and mental health had changed since March 2020, when the pandemic began. And looking at the blue sections of these bars at the bottom, you can see that about 1 in 5, almost 20% of the population said that their physical health had gotten worse. Over 1/4 said that their mental health had gotten worse. And this bar on the right side, that distribution of responses about subjective feelings about change in mental health is what I'll mostly focus on. But in the next slide, I'm presenting a change for a subsample of this sample that had also been surveyed prior to the pandemic in 2018, selected in the same representative way. And looking at responses to 2 identical questions asked in both surveys, you can see that the proportion saying that they were not at all depressed, purple there at the bottom, easiest to look at, dropped dramatically from almost 2/3 to just 1/2, and about the same in terms of people saying that they felt left out. By the same token, of course, the proportion reporting their mental health as being worse independently in these 2 surveys had gone up in fall of 2020. So both the retrospective reports and the comparison between previous and current reports suggest a major decline in mental health. Continuing, and these next slides show how that decline was distributed in terms of basic social characteristics. You can see that the percentage reporting that their mental health had declined was inversely related to age. Older people, less mental health effects, younger people, more mental health effects. And you note in this slide and in some of the others that the impact on mental health does not co-vary with what we know about the morbidity and mortality due to COVID itself. It was not necessarily the people most at risk in terms of physical health who experienced the worst mental health effects going on. In terms of education, another example, people with more education reported worse decline in mental health, a fairly major difference from those with the least education going on. And furthermore, next slide. In terms of ethnicity, again, the blue bars, the people who said that their mental health got worse, it was individuals reporting their race or ethnicity as white and as Asian who were most severely affected. You can see that among the Latinx population and the African American population, there was much less of a sense of decline. And I will add right now that this is actually consistent with a number of different surveys conducted around the country during the same early period of the pandemic. And I'll have more to say about that going forward. Next slide. This also shows that worse mental health reports occurred more amongst single women and somewhat more amongst married women. Next slide elaborates this a bit, showing that people who were working at home were on average reporting more of a mental health decline than those who were not employed, who generally were in a situation that they had not previously been employed either. And people working at home more severely impacted than those who are working away from home. This is, again, in terms of mental health. It certainly doesn't reflect the amount of COVID risk. Again, more to say about this moving ahead. And in this next slide, another kind of related finding. You note that people who said that they had visited others' homes within the last several days, early in the pandemic, not supposed to happen. People were supposed to be isolating. They reported the people who reported visiting others' homes more, 3 to 7 days in the last week, reported less of a worsening, almost no worsening of mental health compared to those who were following the rules and not visiting others in their homes on the left here. I hope that's clear now. And moving ahead, so this analysis kind of puts together these different findings. And let me just note at the outset that this is an analysis of the likelihood of reporting a mental health decline. So less likelihood in this chart is a good thing. In other words, the bar is going to the left. Are people reporting are characteristics associated with less decline in mental health. And again, you see Latinx, Black, and Asian respondents reporting less of a worsening of mental health, whereas women and more educated people, people with more income, and those also who worried more about infection and worried more about their money situation, reporting more decline in mental health. But those who actually said that they had experienced an income loss because of the pandemic were less likely to report that their mental health had declined. Again, in other words, it was not the direct impact of the pandemic itself that created the mental health decline. The next slide, which also presents findings from the same multivariate analysis, shows that the people who said that their mental health had declined were more likely to report over higher levels of distress using a standardized measure. They were more likely to say that they were lonely. They were they reported that they were now spending more time online than they had before the pandemic. And remember, these results are all controlling for these different variables. So the people reporting more mental health decline, that is the ones who said that they were more distressed are removed from the effect of these other variables. So in spite of that, the people going online more were reported more mental health decline, although those who were connecting with friends and family online proportionately more were doing better. On the other hand, those spending more time on social media relative to their online time were doing worse. So this quality of social connection and the way that online relationships were managed was really critical. Those with a religious connection, connecting with a religious community, even online, experienced less decline in mental health. And I will add that these family and friend connections and the religious connection largely explain the preservation of mental health among African-American respondents. Exercise also is helpful. Moving on, just to summarize, it's important to note that the effects of the pandemic on mental health were not directly for the general population. Of course, this is not talking about people who actually were infected, but for the general population were not related to the risk of infection. And to recognize the differences in impact between different social groups, that economic loss per se was not the driver of mental health impacts, even though people with poor economic status may have generally report poor mental health, but that wasn't the pandemic impact itself. There was more resilience in communities of color. And in terms of mental health in this early period of the pandemic, and critical to understanding these effects was social connection, whether people were able to preserve it, whether they had it, and whether they got caught up in this using news to kind of doom scroll about issues during the pandemic. Ways of helping people, of course, are to focus on the importance of this and also to recognize the value of our old friends for mental health exercise and connection with an ongoing community, presumably a religious community being an example of that. Thank you.
Thank you, Russ. Could you stop? Okay, I'm sharing the slides, so I'll stop the slides right now. Yeah, thank you both for really spotlighting two different aspects of the pandemic, one the medical neurological side and the other social side. So we do have about 15 minutes for discussion, and as a way of starting the discussion, I have a couple of things that I want to ask. So first of all, question for Keshav. He brought up a very interesting observation about the signaling problem in long COVID syndrome with parasympathetic sympathetic balance. So that made me start thinking about yoga. Yoga, the main thing that it does is to reset or correct the parasympathetic sympathetic imbalance towards more a cohesive balance. So do you think that yoga might be a key therapeutic approach from that angle as well?
Yeah, definitely it will supplement, it will complement rather, shall I put it that way, the other treatment modalities what we use for long COVID. Not only that, as Professor Shute also had mentioned, see, yoga or meditation or pranayama, they do reduce the incidence or at least the severity of the mental health issues, what we encounter. Others, many patients we did find with a lot of anxiety issues, with a lot of sleep issues, doing yoga, doing meditation did help them try to at least alleviate their symptoms. So I fully agree, yes, it will definitely be of help as a complement to the other modalities of treatment.
Oh, wonderful. So question to Dr. Shute. So here is something that, first of all, you made a very, very important point that spending time with family and spending time with spiritual or religious activity is a positive thing. But spending time online media and, browsing the media for news is a bad thing. So those are very, very good take-home points. But one part of my mind, was kind of being the skeptic, and you will, I'm sure, answer that. And that is it possible that those who are already declining in their mental health end up spending more time on social media and end up less time exercising, end up less time going to church or the temple, and end up less time visiting family? So the cause-effect relationship there, you cannot really straight away assume that. So, your thoughts.
Yes, that is, of course, absolutely the case that in a cross-sectional survey like this, we can't really talk about in any definitive way cause and effect. By controlling for self-reported symptoms of depression and anxiety in the multivariate analysis, I was attempting to remove some of the impact of pre-existing poor mental health from these other influences. But I think we need to look at more longitudinal data to see how the actual changes in these activities actually preceded the changes in mental health. I think we know from experimental research, such as we are involved in now, that the factors that we're talking about in terms of social connection do make a positive difference in terms of mental health, or negative, depending on the quality of those social connections. And in that sense, I feel that the theory behind this is supportive of some expectation that there were effects of the change on subsequent deterioration in mental health.
So let's see whether the audience have any questions before I come back to a couple of other questions for the two of you. I do not see any comments or questions on the chat.
Kesh, we have a raised hand.
Yeah.
Sorry, say it again.
We have a raised hand in the audience if you'd like to ask your question.
Yeah, could you please speak up, whoever is.
Yeah,
I
this
don't
is
see the name.
Lata Mangipudi. I'm the
Oh, hi,
state
Lata.
rep from Keshavan. Wonderful presentation and a lot of good information. For all three of you, you looked at different aspects. As a legislator, for me, what the takeaway was the social impact of social media, the pandemic, And the positive aspect is that telemedicine has brought the global health on a same platform, which is wonderful sharing of resources. At the same time, social media addiction in a negative aspect, that is another digital addiction, I would call that. We are seeing increase in that. How, as policy makers, can we make some good policies to be implemented, not just in my little corner, but something that we can show? Say, for example, Northeast, can we expand telemedicine across Northeast to reduce the digital addiction and enhance the telemedicine, share the resources and knowledge instead of doing pockets of, is that something that I'm looking at?
Oh, those are excellent questions. So, Dr. Shute, do you want to take the question on the social media part?
Thank you for that very excellent question. And this focus on what I would say has become almost a veritable explosion in our time of former methods and meanings of social connection. The center simply has not held with respect to prior understandings of how the social world works. But I will say that I am reassured from our survey data that maintaining social connections, even online, with family, with friends, with a religious community, had positive impacts, which I think many of us experienced as a way of coping with the pandemic. I don't feel that kind of connection is of as high a quality as in-person connection in multiple ways, and certainly in connection to mental health. But I think that one positive step that we can take is to really emphasize the importance of social connection with people who you trust, with friends and family, through online means as ways of staying connected extra locally. Unfortunately, I think the other problems related to social media and in effect going down wormholes of anxiety and fear through following connections is something that has to be tackled at a policy level, affecting social media companies and people who are responsible for driving these negative directions. So I think there's got to be a balance between encouraging proactive use of media and at the same time trying to put guardrails around the online world as a whole.
Yeah, thank you, Russ. Keshav, do you have any thoughts on this?
Dr. Keshav, this is Dilkush Panjwani.
Yeah, sorry, did I hear Kesh? Yeah.
I have a question.
Yes, please.
This is Dilkush Panjwani from Toronto.
Oh, hi, Dilkush.
How are you? Thank you for the very scholarly presentation, all of you. I have just a very quick question for Dr. Keshav. Is there any biological marker via research that would show positively, a sensitive and specific marker for long COVID?
Yeah, the answer I have to say is no. I think I mentioned that in one of my slides that, despite about 3 years of research, I'll also ask Keshav to comment on that. There is no consistent marker, immunological or physiological, that definitively distinguishes someone with long COVID from someone without. But I also would say here that the so-called long COVID is not one thing. It may be a combination of some people with a psychiatric disorder with an exacerbation of a pre-existing anxiety or depression. That could be some people. And there may be a subgroup with an immunological dysfunction that may be similar to the chronic fibromyalgia syndrome, chronic fatigue syndrome. Even for that, there are no specific biomarkers. And there may be some others in whom there is an actual worsening of a neuropsychiatric disorder like cognitive impairment, especially more in the elderly group. Some of the objective measurements of cognition could be useful in monitoring and distinguishing those individuals with a objective cognitive decline versus a subjective brain fog. And so from that point of view, a careful characterization, careful assessment would be useful. So Keshav, I look to you to add anything.
Yeah. Coming to your question, that's why I mentioned very clearly that a long COVID would be a diagnosis by exclusion. So we have to ensure that there is no alternative diagnosis for these symptoms. I'll give you just why this happens is, we had a lot of patients of Parkinson's disease, of patients with dementia, whom we were following even before the COVID. But what we saw was, after the pandemic, when these patients developed COVID, the rate of progression of their underlying disease was fairly fast. So they did deteriorate. They stepped down a few steps down. Now, whether it was the COVID infection, which led down a little bit of the neurodegenerative condition becoming more severe, or whether it was the natural course of the disease, it was difficult to ensure. So that's the reason, like any patients who presents with brain fog or say cognitive dysfunction, we do MRI scan, ensure that he has not developed some infarct or some other neurological problem, which could be responsible rather than just labeling it long. And right now, as of now, we really don't have any biomarkers. It's just like we exclude all other conditions and probably say it fits into long COVID. And there's no one single symptom or no single clinical sign also which can define this syndrome. That's unfortunately the status as of now.
Leads me to
Wonderful.
another question.
Thank you.
That leads to another question. People who have long COVID, are they deemed totally disabled from the insurance point of view? Especially people who are dealing with human lives, professional nurses, doctors, social workers, first firemen and police. So are they deemed totally disabled especially with brain fog, where there are cluster of symptoms? Brain fog is not just one cognitive thing. Fatigue, GI symptoms, many other symptoms found in brain fog. So what's your opinion from the insurance company point of view or the workers' compensation point?
Well, that's an excellent question. In fact, this was evaluated by the American Disabilities Commission. And in fact, they determined that this long COVID would come under qualifying for American Disabilities Convention. So there is recognition that even though objectively you may not find a lot of indicators of cognitive impairment in many individuals, subjectively there is a disability, and that counts a tremendous amount in order to reduce functioning in day-to-day lives. And so it is absolutely the right decision of the American Disabilities Commission to support this.
Thank you.
Yeah, thank you. So we're almost at the end of the time. So Keshav, did you have anything to say before we close?
Yeah, I just want to make a small point. See, what we saw during the pandemic was, it was really the vaccine which was a savior, right? So that really turned the table, and then that's when we really started getting the upper hand over the virus. But unfortunately, this availability of vaccine was very lopsided. So many nations or many states had a really good supply. Countries like, maybe initially we did have, like a lot of other countries also had a lot of problems in getting vaccine. So my only, this one is, I don't know, since we had a policymaker in the meeting, my only suggestion is, like, see, once we have this, there is definitely, we are sure to have more pandemics in future, that's for sure. But if we have to be better prepared for that, my only suggestion is that if the distribution or the availability of these vaccines is better, is, everybody gets a chance or opportunity to get this vaccine, to use this vaccine, I think that will be of great help to ensure that, this pandemic is not as severe as we really faced during the pandemic. That's my opinion.
Yeah, thank you, Kesh. So I think I would like to end with a closing thought of my own. And this is in relation to Dr. Schutz's observation of the relationship between more internet surfing and social media use and more mental health decline. But on the other hand, more family time is actually good. It's something that is very, intuitive, and more work needs to be done. We need to practice this in our lives. And in my own personal example, pandemic and the technology and the social media use was actually a positive thing. Because I never used to get in touch with my family on a regular basis before the pandemic. But since the pandemic, we religiously have a Zoom meeting every week with our family all over the world. I'm sure many of you would resonate with the same thing. And there I want to make the point that use of social media and technology has two parts to it. One is what we call a synchronous use, and the other is the asynchronous use. By synchronous use, we mean bringing people online like we're talking to each other right now, talking to each other in real time. That cannot be negative. It can always be a good thing. But asynchronous use of social media, just throwing a message out and without knowing what the other person's response will be and so on, and working in isolation from each other could be a bad thing. So that may be a key distinction worth pursuing further in studies. So I'll leave at that, and thank you all very much for a very wonderful session, great discussion, and see you all at the next similar webinar. Have a good rest of the day.
Thank you. Thank you, Keshav. Thank you, Professor. Thank you.